So let's start. Our first session today is on improving access to care for survivors of sexual violence, key lessons from mixed method studies for in this scenario. Considered a foundational study to improve access to survivor-centered care for survivors of sexual violence against varied cultural backdrop, this session will highlight some of the socio-cultural considerations and barriers to care, both perceived and institutional. We have three panelists for this session. Maggie Verkutten, who is sexual violence and intimate partner violence specialist with MSF. Nell Gray, the anthropology advisor with MSF's Manson unit in the UK. And Dr. Himanshu Mohan Kumar, the deputy medical coordinator with MSF India.
So good morning and good afternoon to everybody in different time zones. We have the honour to start the first session, which is set up as a panel discussion with Maggie, Himanshu and myself, discussing their sexual and gender-based violence, also called Sgbv. We may also use the terms sexual violence and intimate partner violence. In this 30-minute session, after a short introduction, we'll take you through the key findings of the Sgbv study in India. During the session, you can ask your questions using the chat box, some of which we will aim to address at the end. As an introduction to the topic, sexual and gender-based violence, Sgbv, is a common issue since long in history and across the world and pervasive in all settings, affecting us all, those we try to reach in our work and those we work alongside. Globally, 1 in 14 women experience sexual violence by a non-partner, and 1 in 3 women experience physical and or sexual violence by their intimate partner. In humanitarian emergencies resulting from conflict, it is 1 in 5 women who experience sexual violence. But not only women are affected, Sgbv also affects women and girls, men and boys. And as many know, Sgbv is causing immense harm, suffering, loss of dignity, and immediate and long-lasting medical and psychological consequences. Despite these known consequences, research has shown that survivors of Sgbv often suffer in silence. The multitude of barriers to accessing care contribute to Sgbv being a hidden crisis. Even if survivors would manage to seek medical care, they may not find what they need the most: a supportive response from a trained healthcare provider who knows about provider-centered care, including dignified, free, private, confidential, safe, and quality healthcare. Healthcare providers may not have been trained and are hesitant to recognise or safely ask and respond to all survivors of Sgbv, for example, children sexually abused or male survivors. It's the MSF role to put a response in place, adapted to the context, creating access to quality and comprehensive medical care and psychosocial support. Maybe you might be with us now. But in this session, we will share with you some of the findings from the Sgbv research we did in Delhi, learning about people's knowledge, attitudes, practices, and perceptions. At the end of the session, we will ask for your input through the chat to read what are your ideas for creating and improving access to care. So keep this question in mind during the session. So we'll start with a question for Himanshu, and hopefully Maggie will be able to join us afterwards.
Can you hear me now? Can you hear me now? No?
We can hear you now, yeah.
Yes.
Would you like to ask Himanshu the question?
Yes, so I'm very sorry for the inconvenience. Can you confirm I can be heard right now?
Yes, Maggie, I can hear you.
Thanks a lot, Nell, for stepping in. And I guess before we start to share some of the key findings, let us thank also the collaboration with Dr. Baba Saheb Ambedkar Medical College and Hospital Delhi, but also special thanks for the India team and Rachel, who together with Himanshu led this field study. So yes, as Nell said, we won't have a PowerPoint, we'll use a panel discussion. And let me start with Himanshu to ask you to share a couple of lines about the Sgbv burden in India, but also why and how the CAP study, the Knowledge Attitude Practice study, was done in India. Himanshu, over to you.
Thank you, Maggie. Greetings to everybody. Well, India's SGBV burden is similar to that of the global average. In India, 1 in every 16 women experience SGBV by any perpetrator in their lifetime. And in marriage, 1 in 3 women experience spousal violence. But the core issue is that only 1 in 100 women experiencing SGBV ever sought medical help. Hence, the health consequences of SGBV largely remain unaddressed and undocumented. And our experience in the Delhi SGBV project has been similar, that the service uptake of SGBV survivors is far less than the burden that is there in the project catchment. Hence, we sought to understand the barriers survivors face in accessing medical care after an event of SGBV, and we sought community opinion on what could be the enablers to access to care. So we designed a multi-phase, mixed method, knowledge attitude, practice and perception study, which commonly is known as a CAP study. The first phase was a quantitative study where a representative sample of Jahangirpuri residents were administered a CAP questionnaire. This was followed by a qualitative phase where another sample of the population were interviewed in focus groups. Here we wanted to understand in depth the responses of quantitative CAP participants. Then we interviewed health workers to understand their experiences of providing access to care to survivors of SGBV. So in the end, with all this data, we synthesized barriers and enablers along the pathway for survivors who seek to access care. So evidence from this study is guiding us now to adapt our MSF project in Jahangirpuri. And design of this study enables extrapolation of results to context similar to Jahangirpuri. Also, systemic barriers that are apparent in this study is applicable nationally. Maggie?
Yes, thanks a lot, Himanshu, for this very comprehensive answer. So over to you, Nell. So looking at the findings from the India study, we learned that the physical injuries were the most commonly perceived as a consequence of sexual violence, and death was perceived as the second most. So now, can you share some of the understanding of the risks and the vulnerabilities and the perceived consequences, particularly also from the qualitative findings? Nell, over to you.
Thanks, Maggie. So in terms of risk and vulnerability, our participants clearly felt that women and girls were most vulnerable to sexual violence. But some did also note that boys could also be vulnerable. But it's really notable that rape was generally perceived to be a violent act perpetrated by a stranger, either in a public outdoor space or in a survivor's home. Whilst domestic and intimate partner violence were acknowledged issues, they weren't perceived to be sexual violence as such. Whilst we know that both globally and in India, the perpetrator is most likely to be known to the survivor. On perceived consequences, as you say, overall physical injuries followed by social and psychological problems and death were seen to be the main outcomes for SV survivors. It's interesting to note also that other physical consequences like pregnancy, HIV and STIs mentioned less than physical injuries. So to give an example, one female participant told us she gets pregnant when she is 14 years old, and then she might die because of it. It's also really important to note that the participants in the qualitative data collection emphasized the huge impact experiencing SV had on mental health. They described feelings of stress, shame, and self-blame, and the immense fear of blame, stigma, and impact on their family and future prospects should the incident become known in their community. As one female participant told us, if the girl's reputation is soiled, her life gets destroyed. And a male participant explained how a survivor would ask herself, how will I face society now? It's better to commit suicide, even just to get out of this. Back to you, Maggie.
Thanks a lot, Nell. I remember when we read all of the findings, specifically the qualitative, the quotes, we were all a bit shocked to read the different perceptions from the people. So Himanshu, over to you. So what we learned from the participants from the study, almost all participants believe that survivors need help and care. But participants also felt that most survivors would remain silent due to the different psychological and social consequences, as well the different barriers. Can you tell us about what were the main barriers from the India findings, as well the enablers for people to seek care? Over to you, Himanshu.
Sure, Maggie. Well, the study tells us that over 90% of survivors will remain silent despite suffering health consequences. This silence is influenced, as Nell mentioned, by social stigma. Any unsafe disclosure will question the family honor, social standing, and may ruin one's future, including possibility of marriage. However, if the survivor chooses to disclose to a confidant for whatever reasons, still the decision of accessing medical care will be that of the family. Perception of reporting to the police before seeking medical care is a major barrier to access care. Added to this is the fear of being stigmatized by healthcare workers, undignified care, fear of wider community knowledge of the event due to lack of confidentiality, long waiting queues at the hospital, possible bribes, or high cost of care and treatment at private hospitals, or low quality of care. What we learned about the enablers of care is that first, knowledge in the community regarding importance of care and knowledge of where to find it, combined with family support and support of friends, is essential to access care. And at the service level, dignified and confidential treatment at government hospitals without police involvement were enablers of access to care, Maggie.
Yeah, thanks a lot, Himanshu. That was another shocking fact, right? That people felt that one of the main barriers was also the perception that people do have to report to the police first.
Indeed, indeed, indeed.
Yeah. So now, next question is for you. So there were a lot of findings from this mixed method study, quantitative, qualitative findings. So can you share with us how the findings were used with the community? So back to the people from who we took the information for further feedback to them, as well to use this as the next consultation with the community. But over to you, Nell.
Thanks, Maggie. Yeah, so as you say, a really important part of our study process was to share the findings with people who participated in the study and to discuss them further with them. And this was important for three main reasons. One, I think, basically from an ethical perspective, as people gave their time and energy to participate, it was our obligation to share with them the collective results of that. But also, secondly, it was a really important opportunity to validate our findings, so to cross-check that the people that participated in the study felt that our findings reflected their perspectives. And lastly, it was also really important to take the opportunity to discuss and explore with them certain issue, action points or suggestions they had for moving forward. And the discussions that we had with the participant groups were really rich and valuable, and people generally agreed with the findings and emphasized certain aspects. Again, for example, they emphasized the major psychological and social impacts for Sgbv survivors and resonated that stigma causes silence. And they also made specific suggestions for future action, which the India team have incorporated into their activity planning and are working on now. Thanks.
Yeah, thanks a lot, Nell. It shows again how important it is when we do a research, when we take information from the people, we also have to give back the feedback. And we were very pleased that this was done in the India mission. So I remind you another thing, what happened after the study and after the analysis. Also an India mission organized a roundtable discussion with key actors to share with them the findings, to discuss possible next steps. Can you share with us the key recommendations from the roundtable discussion? Over to you.
Sure, Maggie. Sure. So the key actors with whom we discussed the study and its recommendations were policymakers, leaders of healthcare providers, academicians, leaders of legal services, and the community actors. All of those who were involved in planning, organization, and delivery of SGBV care. MSF put forth 4 key recommendations for policy change and hence change in systems. Largely, all stakeholders agreed to partake in the efforts at their own levels to implement recommendations, like, firstly, exploring models of community-based survivor-centered SGBV care with social support to survivors and referral linkages to higher centers of care. Secondly, to work with media organizations to challenge the dominant narrative around SGBV, which primarily discusses negative social constructs and punitive legal actions. Rather, the narrative around SGBV should focus on medical, psychological, and social relief to the survivors. Thirdly, to work with the health systems and to increase awareness in the community about why, when, how, and where to seek SGBV care. This effort includes developing and standardizing health messages and tools of message delivery. And finally, to lobby and support policymakers and also the health system leaders to capacitate the health workers at all levels in providing survivor-centric quality medical care by overcoming all the barriers of perceived mandatory police reporting. MSF has already begun to implement some of these recommendations, while few others are delayed due to this COVID outbreak. Maggie.
Yeah. Thanks a lot, Himanshu. It was a very important step for the India Daily SGBV project to be able to organize this roundtable. And we look forward to make the next step with other key actors who were engaged with us in that roundtable discussion. So perhaps because looking at the time, perhaps we can reflect a bit also with you, Nell and Himanshu. What would you like the audience to take away from the study, but also from this session? Perhaps Nell first and then Himanshu.
Thanks, Maggie. It's a difficult question, but for me, I think we know that the stigma and fear of social consequences has a huge impact on survivors wherever they are in the world. But it really struck me here that survivors and their families are often paralyzed by this, especially when accessing services or support is felt to directly result in disclosing the incident to the broader community. So here, the importance of changing the narrative from stigma to support, and at the same time, really ensuring that care is confidential and respectful is absolutely critical. Thanks, Nick.
Yeah. Himanshu?
Well, enabling medical care access to survivors of SGBV firstly requires a change in social narrative around SGBV. It should move towards needs of the survivor. And then increased community awareness of what, when, why, and how to seek medical care to the survivors. These two efforts can lead to a supportive community environment, which is quite essential. In addition to this, we need policy level changes to remove mandatory police reporting during and after medical care, and then capacitate our health systems to provide quality survivor-centric care very close to the community. That would be my take-home message.
And how about you, Maggie? What would you like people to take away from the session?
Okay, thanks, Nell. Let me do that while I also give a quick summary of the session, as I get signs that time is running. So we talk about the perceived consequences of SGBV, and we learn, as what Nell and Himanshu both explained, that the psychological and social consequences were viewed to be the most severe, as well, so connected with each other and having a long-lasting impact on the life of survivors. And all of this results in survivors facing huge barriers to access care from all levels, from family, from community, but also from the health and from the legal system. And these findings highlight that it is key for MSF, no matter where, to have an in-depth understanding of context-specific factors impacting access to care, as every context has its own factors. At the same time, we also see similar findings across the different settings, such as lack of trained healthcare staff, lack of survivor-centered principles such as informed consent, privacy, confidentiality. And across missions, we also continue to see a lack of knowledge in the community. But also, additionally, there are well-known policies at national levels which negatively impact access and provision of care. Gap studies, such as this study we did in India, but also in Haiti, using mixed methods, they provide MSF with further insight how to work at all these levels. For example, how do we adapt engagement strategies with the communities with whom we can work as active agents? For example, when we reach out to specific groups such as adolescents, discussing their suggestions and building next steps together. But also, as Himanshu says, how can we adapt models of care adapted to the context to improve access to services? But also crucial to put in place quality, comprehensive medical care and psychosocial support with trained healthcare workers who will say, it is not your fault, it's very good you have come. So providing survivor-centered care. And as well, what Himanshu mentioned clearly, to engage at different levels, national level, to see how we can, as MSF, influence policy change. To me, all of these links exactly to the role of MSF, responding to survivors of sexual and intimate partner violence.
Last 5 minutes, please.
So I guess my takeaway message is that in current times, survivors should not have to suffer in silence. The silver lining for MSF is that I strongly believe that MSF, in collaboration with other actors, can make a difference in the life of survivors, ensuring they manage to access and receive the support they need to heal and to recover. We will now look into some
more minutes,
questions from the audience. Pooja, how much time do we have left?
5 more minutes.
Yeah. Okay. So I got different messages from the India committee on my WhatsApp. Let me open. So one of the questions I see is if we can share something about other experiences from the Asia region for both engagement and models of care. Second, on the shadow pandemic of the COVID-19 and Sgbv, and other questions. What means quality of care for survivors of Sgbv? So Himanshu, would you like to start with quality of care after I can share also some examples from the Asia region, or you prefer the other way around? Tell me.
Well, I can talk about quality of care. So thank you for this. So what means by quality of care? So provision of quality care includes a few things. Like care needs to be complete, like offering a complete package of care, including safe abortions and abortion on request. And the care needs to be based on survivor-centered principles, which includes privacy, confidentiality, informed consent, respect, compassion, and non-discrimination. Our study findings suggest that the psychological and social consequences can be very severe. So when survivor-centered principles are not ensured, survivors may face even more stigma, or it also can lead to death. So in addition to providing medical and psychological support, we need to offer a medical certificate, do a risk assessment for safety, and plan with the survivor a safety pathway, and also develop or plan together with the survivor a referral pathway for other support services. Maggie?
Okay, thanks a lot, Himanshu. Perhaps I can take the question about what are other experiences in the Asia region for both community engagement and models of care. Is that okay? So I guess we have a number of different examples also from the Asia region where MSF teams have done tremendous work adapting community engagement strategies as well models of care. So different examples come to my mind. If I think of the Afghanistan team, I remember when we did the assessment in Lashkargah in the Helmand province in 2016, it was felt by the staff, we cannot talk about Sgbv in the MOH hospital. The team cannot go into the community because of the insecurity, but the team from Afghanistan, they have made a difference. They say, now we can talk about Sgbv in this hospital. So what they did, they have trained staff in many different departments. They created a safe space within the government hospital, what they call support room. The supervisor from the emergency room, he has set up a safe space within the emergency room, as well with a counselor there all the time. So I think it's amazing what Afghanistan team put in place in a very challenging context. For example, in 2019, they provided care for more than 1,000 Sgbv survivors, including also men and boys. If I think of Bangladesh team, where we have different projects, so we have the projects in Cox's Bazar, where the team works with the Rohingya refugees, and we have the project in Kamrang HR. So let me first quickly say something about the Cox project. So the team works with Rohingya refugees, the women health promoters who do the community engagement about Sgbv awareness raising about the topic. But they also have henna sessions with the adolescents because we want to make sure that this group is also not forgotten. So they do henna sessions within the homes of the people. And the care in the clinic is set up in an integrated way. Well, if I look at the teams in Myanmar, where the team, of course, in Rakhine works with the Rohingya population, the team is using a community-based model. So trained community health workers and traditional birth attendants, they do provide the first aid response in the community. Going back to Bangladesh, for another example, in Kamrang HR, in the slum, MSF has a clinic there with SRH services, occupational health, but also sexual violence and intimate partner violence. It's in the middle of the community. So it's like a semi-vertical clinic. And all of the women and girls coming to the SRH services are asked if they have experienced any unwanted touching, any unwanted sexual experience. This is done in a safe space by well-trained staff. And of course, if needed, they are referred for the sexual violence or intimate partner violence care. But also to use an example from our wonderful project, the Delhi Umikikiran Clinic, where the team works with the community ASHA workers who are working for the government, who are our eyes and ears in the community, and they support survivors to access care to the Umikikiran Clinic. So I guess across missions, we have a number of different engagement strategies and different models of care. And this is all adapted based on the learning, what MSF is doing and can do from the context. Pooja, do we have time for the other question? Well, there are many more questions I see.
I guess, Maggie, we could wrap up. I mean, we can meet in the networking lounge with the audience and you can probably answer their questions there. Is that okay? Yeah.
Okay, so let's respond to the other questions then in the lounge. And let me end then this session by first asking the audience to please share your ideas on the chat, because your ideas, your creative views after this session, share with us what else, tell us what can MSF do to increase the access to care for survivors of sexual violence and intimate partner violence. So on behalf of Nell and Himanshu, we like to thank you for your audience and your attention. And and for us to be able to have this session in the Asia Scientific Day. Thank you very much.
Thank you so much, Maggie, Nell, and Dr. Himanshu for this insightful discussion on an issue equal parts pervasive as stigmatized. Apologies for not being able to take more questions. Please do meet the presenters in the network lounge.